Good afternoon and welcome to today's webinar. A few housekeeping items before we get started. CEs are provided for today's webinar for administrators, nurses, Minnesota social workers, and case managers to all those that attend the entire session. Certificates will be sent in about 10 days. You will see a survey at the end of the webinar. If you would please just take a moment to complete that at the end of the webinar, we would appreciate that. The recording and summary will be posted on the Advancing Excellence website in about 2 weeks. So please check that out and then also share the recording with your colleagues that were unable to attend today. There are no handouts for today's webinar because we are having just a panel discussion. So rather than bore everyone with a PowerPoint, we thought it would be much better to have conversation today. With that, I'd like to welcome our panelists today. Welcome.
Okay. I'd like to also welcome you to today's Spotlight webinar, Person-Centered Care. Isn't that what we've always done? I'm Barbara Bowers, and I'm a longtime member of Advancing Excellence and will be the moderator for today's panel. Let me just tell you a little bit about Advancing Excellence. It's a collaborative, Advancing Excellence in Long-Term Care. It's membership-based, not-for-profit national organization, and we provide a forum for government, professional, consumer, trade, clinical, individual stakeholders to discuss perspectives, policies, regulations, environmental trends in the industry, anything that affects post-acute and long-term care. Our members are great at sharing information and resources. We meet monthly, and our goal is pretty simple. It's to help make nursing homes better places to live, work, and visit. And just so you know, we always welcome new members. And if you go to the Advancing Excellence website, advancingexcellence.org, there is a place for you to send in an application for membership. Today we have a panel with three experts on person-centered care from quite different vantage points. So I think it's going to be a great conversation. Let me introduce our speakers. Deek Cateau is CEO of AG Roads, which is a nonprofit organization that operates 3 nursing homes in the Atlanta area. Deek has more than 25 years of experience in long-term care, serves on multiple boards, including Leading Age, Moving Forward, LifeLoop Senior Technologies, Advisory Board of Donahue Project on Medicaid Nursing Home Reimbursement, Staffing, and Quality. Deek is widely recognized for his work on advising organizations and leaders in the industry on topics related to person-centered care, and I know he does a lot on leadership as well, workforce development, strategic planning, and governance, so lots of expertise. He's also certified as a dementia practitioner and certified as an Alzheimer's disease and dementia trainer. In 2021, Deek published a great book. If you haven't read it, I would highly recommend it. Brushfire, COVID-19 and Our Nursing Homes was an Amazon bestseller. So I recommend it to anyone who's interested in having an insider's view of what happened during the pandemic. Next is Lacey Cornelison. Lacey is currently the director of the Kansas Peak Program and Kansas State University Center on Aging. The Peak Program is promoting excellence alternatives in Kansas related to long-term care. She holds a long-term care administrator's license, has a bachelor's degree in social work, served in direct leadership, clinical practice positions, and is well known for her innovative work in person-centered long-term care. She's been a trainer for SafeServe, Eden Alternative, Person First, and Dementia Care. And she conducts assessments of person-centered care adoption in long-term care organization and consults on person-centered care implementation. Lacey has many publications and currently is a recipient of a grant on resident goals, preferences, and priorities. It's a pilot study. And Lacey, you can let people know if you're still looking for nursing homes. Don't know if you are.
Right now.
Okay. She serves as chairperson of the chair of the Person-Centered Planning Committee Moving Forward Coalition. So welcome, Lacey. Susan Ryan, whom many of you I'm sure know, she has over 35 years of experience in long-term care innovation. She had a lead role in the Greenhouse Initiative, which I'm sure everyone's familiar with, She's currently the CEO of Aging In, formerly the Center for Innovation, a global nonprofit organization focuses on person-directed living and empowered cultures for staff and residents. Susan is internationally recognized in long-term care reform and for her work in the greenhouse and small house programs as person-directed alternatives to traditional nursing home living. Under her leadership, Aging In continues to work toward a future where each elder experiences high-quality, person-directed living in the setting of their choice. So welcome to all three of our presenters. And I just want to review the objectives for today. Just read those. We hope at the end of this presentation, you will have better understanding of the complexities and nuances of person-centered care. You'll have a clearer idea about how to increase person-centered care practices in your organization. And you'll understand how managers and leaders in an organization can actively support person-centered care practices. And I think there are no handouts today, but there will be a follow-up summary, which we will post on the Advancing Excellence website, and the recording will be available. I think that's about it. If you have not received a survey from us about your ideas for future Spotlight series, you will likely be receiving one soon. Okay. With that, I would like to get on with not introducing, but actually engaging our panelists in a great conversation. So let's start by addressing what was really the title of the webinar today. What do we mean by person-centered care? What actually is it? And how does it differ from what we've been doing in the past? And isn't it what we've always done? So let me start with you, Susan.
Well, I'm going to take this opportunity to utilize a framework that Pioneer Network actually was responsible for doing. And we were actually just talking about it before we started the webinar today. And that really is the continuum of getting us to person-directedness. And when you think about where we were decades ago, we were very much provider-directed. And decisions and the way things happened were really very much hierarchical. They kind of flowed from leadership, and they said, this is what we do. Residents accommodated to what the organization needed to have happen. We shifted a bit and we went more staff centric. And we said, okay, so staff will be making decisions. So we're kind of moving that locus of control and power to really the staff and working in collaboration with residents, but still residents are still kind of acquiescent to the rhythm and the flow of the staff and what they think is important. Now we're getting to person-centeredness, where we are saying we need to know who that person is, what those person's preferences are, so that we can center their care around who that person is and what's important to that person. And that's a great place to be. You have to recognize this is where we are coming from. And to get to this place is a new place where that person, we're really centering care around that person. I'm going to challenge us to even go further and along this continuum to person-directed living, which when you were reading, what Aging In is about, it's really to get us to this place where it's not just centering care around a person's preferences, but it's understanding that person and how can that person be more in the driver's seat to really direct their living experiences, their rhythm and routine for the day. And Deke, you reminded me of Jill Vitale Awesome and kind of taking us again to that next level. How do we really create citizenship and more of that sense of autonomy? We're here to talk about person-centeredness today and really making sure we deeply know who that person is so we can really better understand how do we create care plans, how do we really understand their preferences and really make sure their day is really being accommodated by who they are and what they need to live meaningful.
Thank you. Anybody else want to jump in?
Sure, I'm happy to. When I think about person-centered care, and Susan did a really great job of laying it out, so I think similarly, I also think of it on different levels, like that person-centered can be a one-on-one interaction or small group interaction. Um, with in how we interact with the person, but it's also at a systems and organization level. And I think part of the reason that um, it's different from what we've always done is that we have to change systems in order to truly support person-centered care. And one of the questions you asked is, aren't we already doing it? And I often share with uh, people to kind of give a concrete example is to talk about the bib. And I ask, do you use bibs anymore? They say, oh, no, 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 no. We have clothing protectors. And I put up a picture of those two side by side, and they look exactly the same. And so, person-centered care is not relabeling what we're already doing, it is doing it differently. So, we no longer provide the bibs, we provide cloth napkins or paper napkins, and individually care plan for people who might need something a little bit more than that. That's the difference here. It's a true shift. So,
I would jump up all on what Susan and Lacey said. I agree completely with both. Lacey, I'm going to speak to what you just said again from a practitioner in the field. And I do think and I was brought up that way too. We get carried away with just the language, which is important. It is extremely important. What you say manifests what you do, but what you do is more important than what you say. And that's a key point. I'm also going to touch, Susan, on what you said about rhythm, and that is my personal definition of what person-centeredness is, or person-centered care. It is allowing or adjusting our schedules to the rhythm, the cadence of the life of a resident. I have a rhythm to my life. Lacey, you do. Bob, you do. Susan, you do. We all have different rhythms. And that's where the difficulty comes in, because it's very difficult to adjust to the cadence and the rhythms of different individuals. But that's what I think it is. I think it is getting to as close to that point. I don't think we will ever get fully to that point. I don't think that's humanly definable in a communal setting. Unless we have one-to-one staffing, which is not going to happen. We all know that. But it is adjusting our life, as Susan said, as the providers, to the rhythm and to the cadence of the people we care for.
Can you, Deke, or either the other two of you, give an example of how that would work?
I'll jump in, and Susan again touched on some of it, which is why the early process of admissions and knowing who these people are becomes so important. But I have one individual in particular who I'm amazed with. He's a resident. He lives in our Atlanta home. I would not call his name, although he would be fine with me calling it. But his rhythm is so different than most of the residents we take care of. Of course, he needs nursing home level care. He's an elder, like all that we take care of. But his rhythm is more like, leave me alone.
Hmm.
I'm gonna do this at this time. I'm gonna have this for breakfast. But sometimes we cannot accommodate, and he's fine with that. He'll get it from elsewhere. This is what I'm gonna do at dinner time. This is my cadence. And we struggled for a long time with him, literally with stuff that, hey, most of the stuff he's asking for, we don't even have to do. But because, as Susan said, we're in this institutionalized setting where the provider, we expect, hey, we need to wake you up, you need to do this, you need to eat here. We were so struck with doing that we didn't realize, hey, he was actually making our lives a lot easier doing it. I have other examples I could give you on the other side of it, but I love that one. I always give that example because he's actually made our life easier without us realizing it. Now, the flip side, Bob, is that people would make their individuals, their illness that would make lives more difficult by doing it.
I could add a little bit to this, that the work with the Moving Forward Coalition and finding out residents' goals, preferences, and priorities in their care just really is a fundamental aspect of person-centered care and being able to do it, finding out what's important to them, what matters to them, and integrating that into care all throughout, and making sure that people who are doing the daily care know those things and can um, communicate new things that they're learning around that. So there's some resources on the national level. There's an actual guidebook that can help homes with systems um, that can do that. And I'll talk a little bit about peak, but one powerful example that I like to describe is a home that um, really does a lot to know as much as they can about the residents before they move in. And they actually have a resident welcome committee that intentionally, when a person's first coming in, connects with them and helps them kind of get to know the home from a resident's perspective. And so when they're learning information, they learn a lot when they come in, but some key stuff are their favorite snacks, a comfort meal, and some of their toiletry products that, are important to them. And they create a welcome basket that includes those things, and they cook their comfort meal within the 24 hours that they're there.
Wow.
Which I think is just incredible because you think about what that transition is for people, and um, that 24 hours is pretty critical. Now, there's some people who are very sick that, may not even really realize that, but think about the smells of your favorite comfort meal and just the recognition of some of those things that are familiar to you. That's a big deal. So I think that it's the big things and the small things, and it's systems that allow us to be flexible enough to support people in their different rhythms because we do have different rhythms. So how food is delivered and when it's available, how baths are organized, how we staff, all those things are systems, things that make it so we're not having to work against a system that's there, but the system works for us so that we can be responsive.
Great examples.
I'm going to
Yeah.
just add a couple things to that. I have used a framework before years ago, um, one that's easy to remember, IRS. So IRS is a framework where you go individual
That's
discovery.
not my IRS, Susan. Let me just,
So
I was about to
you won't
write it down, but I
forget
was,
IRS. So IRS, it starts with the individual discovery. And that is what is key to this person-centered care, really knowing who that person is. The R is routine and rhythm, to get back to, putting the punctuation on that or the exclamation on that. So what is the routine and the rhythm of that person? And it doesn't happen at just one fell swoop where you sit down and you discover that person. It's iterative. It happens over time. It's with family members. It's those observations that you're seeing of that person. What is their routine? What is their rhythm? What feels good? What feels right? And then from structure and spontaneity, what kind of structure? What are some of those planned things that you will do from a structural perspective? And then what are those things that will happen more spontaneously? And I will give you an example. I was visiting a greenhouse home years ago, and I remember there was an elder in the home it was the afternoon and she was becoming a bit anxious. This was a woman who was 100 years old. She had lived in the greenhouse home for several months. And at that time, what they knew about this woman is that she loved ice cream. And so they were saying, well, why don't we have some ice cream? And she got very excited about that, sat down to have the ice cream. And then suddenly, spontaneously, the other elders in the home thought, well, I want some ice cream. And they spontaneously had an ice cream social. And so it was something that happened, by knowing who that person is spontaneously, they were able to do some things, really tap into kind of her routine, her rhythm, and what was going to be helpful to her. But having that framework that starts with an individual discovery and really understanding the individual discovery in a context of the routine and the rhythm. And what do we plan for, and where can we really see some of those moments more spontaneously?
Great. So I want to move on to There are lots of obstacles, things that kind of get in the way of providing patient-centered or patient-directed care, person-directed care. What are some of the strategies that you've seen to overcome those obstacles? I think we probably all know the obstacles. So how do you overcome them? Deke, you want to?
Yeah, I don't think we all know the obstacles. So the obstacles are different in different settings.
Mm.
All right. So I would say, as someone who has run independent living, assisted living, and now skilled nursing for many years, it was much easier to implement person-centered practices in independent living and assisted living.
Mm.
So I'm gonna predicate this conversation, which I'm sure Lacey and Susan will step in hard on, to understanding that a lot of people don't realize how different it is. A lot of people assume it is so easy, this is what should be happening in nursing homes around the nation. It is not easy, and it's not how we have been taught or how we've been regulated to do. So I think we are actually, as a nation, at a changing point where I think regulations need to change in order us to embrace person-centered care, which we all agree that's the right thing. I mean, that will never be in doubt. But I do think there are huge obstacles, regulatory and otherwise, even just the punitive nature of our regulatory process. It's hard. As a provider, we are on eggshells. Like,
Yeah.
what are they looking for? What can we do? What shouldn't we do? And sometimes we neglect person-centered care because of that.
Mm-hmm.
Because we're scared of what we would do and what that would. And I know we have a huge audience here, so I know some of them would say that shouldn't be the case or BS. But I'm just telling you, realistically, living on the ground in a nursing home world, it is very, very difficult to implement some. And I'm talking this as a provider who has implemented person directedness, and it has taken many years and will take many years further. But we always come into hiccups. We get a citation, something happens, a family member complains, they want rails on their bed, right? And it just derails, no pun intended, but it derails a lot of the well-intentioned part of it. So these calls are great, but I think there's systemic issues that we have to be realistic with and deal with it.
So give us some tips for dealing with it.
The tips are, well, one of the first one is a very difficult one, that you may have to be prepared to get in trouble and to get cited, to take citations. The reason I say that's difficult is I have had a citation for giving person-directed care that has cost my organization hundreds of thousands of dollars, right? So it's a hard piece of advice, because if you get that, you could lose your job for that. I did not, right? The other tip I would give is it has to be leadership driven. Leaders have to commit to wanting to do this. And Bob, in preparation for this, full disclosure, I believe in transparency. You sent us some articles about how leaders can do this, and how, in particular, how mid-management could do it. If you do not have a total commitment from the start, from the head leadership, mid-management can do nothing with this. If there's not that total commitment, because of what I just told you. Because when the hundreds of thousands of dollars and the fines and the issues come, someone will get fired, and that would derail everything with it. So there has to be a total organizational commitment. The other thing I would say going down is you need leaders on the floor. I'm talking informal leaders. You need people who the real leadership is going to invest in to make sure this happens. These are the people that will call me now to this day as a CEO of a company of several nursing homes, who will call me and say, hey, we have an ASU on this unit or that floor. So you need these informal leaders to push it forward, but they need that drive, literally, from the top to be able to make it happen. The last thing I would say is you need a point person to be in charge of it, which is why leadership needs to be involved because they need to invest in that. I have been lucky and grateful to have someone. I used to serve that role. One individual in the leadership level whose charge is to change the culture of the organization or to help change the culture of the organization. If one person, and that has to be their full day job, not do this and do activities, which is normally the point. Not do this and do communication. That's your only job to help drive that culture. I was fortunate to have that job for 2 years. I'm fortunate now to have someone doing it going forward.
So before we go on to the other two, can you say a little bit more about what do you mean by management leadership support? What do people actually do?
So leadership is important in everything.
Mm-hmm.
Management is important in most things. and that's just my view on it. What you need leaders to do is to literally insist on this is what the organization is going to do. This is the pathway. We will have humps. We will have bumps. That is what leadership is. Leadership is exactly that. Leadership is taking that target, that direction, and driving it down. And just as important, leadership says, hey, we need to make $50,000 every month, or $100,000 every month, or $1 million every month. That is how direct I'm saying this is. Leadership has to say, this absolutely has to happen, and measure it and find the right KPIs to measure it each and every month. I cannot say it simpler than that, Bob. That's what I'm saying.
Yeah. So it's great follow through and accountability.
Forget follow through and accountability. I'm just saying, let's talk real language.
Yeah.
I'm talking leadership.
Yeah.
Has to insist. That's my word, not follow through and accountability. Has to insist. This is going to happen. These are the timelines it's going to happen in. 6 months, 12 months, 24 months. I've told you all my journey already. We are not even near to being person-centered. But guess what? Our leadership has made a decision and set a pathway on us to get there.
Thanks, Deke. Great.
So let me build on that and just say it's all about leadership. And to put, again, what Deke has just said, I mean, it truly is. I'm going to give you another framework, something that we think about. It's beliefs, behaviors, and systems. And I think, it's got to be mindset shifts. And we've got to believe, and Deke, I think you're alluding to this, is that you have said this is not negotiable. This is our belief that this is what elders deserve. And this is where we're going. We are shifting that mindset to that provider directed or even staff directed to we want person-centeredness to happen here. So those are our new beliefs. And then what are those behaviors? You talked about KPIs. You talked about the expectations that you have. So what are the behaviors that we want to see? And then Lacey, I think earlier you were talking about systems and what systems need to change. If we try to do person-centered care in an institutional frame, a mindset and institutional systems, that institutional system will win every time. And so what are some of these new systems that we need to do? Another comment that I'm going to make is to hit the regulators and the surveyors and the work that needs to be done. I attend annually the Association of Health Facilities State Survey Agency Directors Conference. Annually, I go there because culture change cannot occur in silos. And we have some person-centered regulations. Do we need reform? I believe, yes, we do. Do I believe you cannot punish your way to quality and to person-centeredness? So yes, I believe there needs to be reform.
Susan, I'm gonna jump in. Not just do you
Please.
go there, you speak at it. You speak at their conferences, and you get
Yes,
more voice.
yes. Exactly, exactly. I mean, we're talking dignity of risk. Liza Behrens and I, we spoke last year on dignity of risk and how important it is, our preoccupation with safety, 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 and to the risky preferences and such. We do stakeholder groups with the surveyors to talk about these things. So being very intentional about what that looks like to build stakeholder relationship so that we are working together towards the vision that we all want to see. And that is where that it's person-centeredness happening there.
Lacey? Yeah.
I can jump right in here. I really liked what Deke said about the leadership, especially from the top, needs to be clear about what is going to happen and that you're committed to it. I think another challenge of actualizing this in real time is you can know the what, but it's the how. It's the
Mhm.
operationalizing it day to day, and that can be a real stumbling block for people. And I think that's where really operationalizing what this can look like, not saying prescribing how, but really what are some of the features of systems in operation that support person-centered care. And here in Kansas, with the PEAK program, there are there's a framework that really outlines kind of what is person-centered care that has drawn from the frameworks of the greenhouse model, from literature, from the household model, and so forth over time, and really tried to capture what are those, when you think about artifacts of culture change, some of those things in a framework that can help people really see or break down what this could look like so that you can actually kind of develop a strategic plan to go forward. And so, for instance, like I can give you an example in Peak, there are four domains with resident choice, staff empowerment, the environment, which I'll note this is a question later. The environment requires no financial outlay except for removing the nurses station. So that it's not necessary to demolish and build new or renovate to do this. And then the last one's meaningful life. And so, like one of the areas of food, some of the key outcomes there are that you have an enhanced dining program, that food's available 24/7, not necessarily self-serve, but it's available 24/7. Um, that the meal times are expanded. And so you can see, so there's some specific touch points on how to really operationalize what does this look like across multiple different areas. The other thing about leadership that I would say is there's a lot here, like to unpack with leadership. So keep asking questions about it because more will come out.
Yeah.
Yeah, but I think that it's really important to establish a learning organization, which is kind of what Deke was talking about, where it's so punitive in long-term care that even the way we lead is very disciplinary, action related. So developing ways of coaching and training people and, failing forward kind of mentality versus the, you make a mistake, boom, I'm going to ding you kind of situation. And having that helps support employees to not have to be in fear a little bit and also gives them that scaffolding to be able to grow. So I think that's an important one. I also think as you're thinking about change management, because let's be real, change has to happen if you're going to truly realize person-centered care. And I'd say that's another challenge because change can be inevitably hard. In various ways, but that you engage people in that process. So it's kind of an irony if you were to mandate person-centered care in your home. Yes,
Yeah.
that doesn't really work, right? Just like if you're mandating residents to live a certain way, it's not person-centered care. And so, as you're making the changes, really knowing what you're changing, but engaging people in that how, and really kind of figuring out how is this going to look or work here. And I think that that can really bring investment in it and buy in. And it is harder in some respects to do that, but really key places really get that engagement from people at all levels of the organization, especially people who it affects.
Yeah, great. Well, this kind of leads to a question that I wanted to ask you
Bob,
about.
can I
Oh,
jump
yeah.
in really
Yep, go
quickly?
ahead,
Again,
Dee.
I hate to take this to that. So
Sure.
again, agree with everything Lacey said, but I would just say from someone on the ground who's run nursing homes, so the environmental changes where they sound like they're not going to cost, there is a cost to every one of those changes. If you're removing a nursing station, there's a cost. If you are not removing a nursing station, there is absolutely a cost to the reality that that's where nurses normally stay and sit, and then going to be in different environments. But more importantly, to change the culture of the organization to understand that we're not using the nursing station needs as a huge cost. Food, there's a cost to everything you mentioned, Lacey. There's a absolutely a cost. I personally agree with you, and I think in the long term, you're actually going to save money
Right.
or yeah on some of it. But there's a real cost to it, and I'm just saying as an advocate of someone who runs communities, there is a cost, and people are held liable to that cost each month, i.e. the administrator of it.
Mm-hmm.
Yeah, so that's what makes this so dirty, so nasty, so yeah to do.
Yeah. Yeah, I want to clarify that I was responding to like, in order to do this, do you have to build new in order to do this? And I don't think so. But there, I
But there's still a
feel
cost.
like
There's still a cost.
it does
Yeah.
cost. And one of the things I would say that, as you're pushing through this and I think on a policy level, there's some opportunities here because Peak offers some Medicaid incentives for homes who engage in this. But whenever you change something systems wise in your organization, if you are forced to change something because a new regulation comes out or you implement a new EMAR system or whatever, there's training costs up front that go along with that
Mhm.
cost your organization. There's, setting things up and changing things over. And so, up front, you do have to think about, that changeover cost, but it's not something that will necessarily last forever because once you learn it and once you're there, that system reinforces itself, hopefully, which is why it's kind of hard to get out of the system we're in because we have to have this changeover and then get, resettle.
And Lacey, that's what our movement, you, me, Susan, Bob, and we are all involved, Jay, with the Moving Forward Coalition. What we have done a horrible job, is of showing exactly what you said there. Showing how it will be a savings in the
Mhm.
long run, right? We've done a bad job of quantifying
Yes.
what's the savings that will be involved in this as a
Especially when there's short-term increases. Seems
totally,
to, yeah,
completely.
It's
We've
that's,
all
lost
you
a lot
can
of time.
see.
Yeah.
yeah,
Yeah.
it's all
So,
you can see.
yeah. So we're on the
Okay.
same page, Lacey. We're on the same page.
Awesome. You said
Very
it
good.
so gracefully.
Yes. All right. I want to ask a question that I think follows up a bit on what Lacey was just saying, and that is, I know that direct care staff get some mixed messages about person being person-centered, but also following the rules, complying, not getting us into trouble. But another challenge with direct care staff, I think, is people need to have their heart in this. You can't just do person-centered tasks and say, check, check, I did it, I'm person-centered. How do we help people become the person who just feels it in their heart and does it? Deke, you want to start?
Yeah, you can't. Um, so I've been in this business for a while now, and a lot of people fake it. A lot of people. I used to be in interviews. I'm not anymore, obviously, because of my role. So and I'm going to talk to the direct care staff now, who
Mm-hmm.
I think are the most precious. They're closest to the resident. And a lot of them fake it. They've taken care of their mom or their grandmom. And I'm not, audience, please do not think I'm a bad person by saying this. And that's their qualification to come into it, which is nice. but it's totally different of taking care of an elder
Yeah.
who has dementia, who you have no relation to, who chooses to smack you in the face, right? That's when I see your real dedication and compassion to this. The other issue I have is that we have an industry where you can be the best staff member. I was suspended as a payroll coordinator, payroll HR coordinator from a nursing home because a resident said a black male African, which I'm not, but I'm black and male, but I'm not African, on the night shift hit them. And I fit the description, and she said it was me, and I was suspended. And that is a hard reality of people given direct care, which is what I think we will never be, unless that changes. I will go work in the hospital. I'll go work in the doctor's office before I do that. That's a reality of a preparation. Now I was brought back to work, and most of our CNAs in this industry are brought back to work as well, right? If nothing has happened, but it's a reality. The regulations point towards that. So, Bob, that's a hard question for me because I mean, I just have to be very realistic with you. That there are few that do have that in them, and we know it. We know the few, but the demand is so hard now for staff, and the supply is so low that a lot of people don't come with that qualification. A lot of people fake it, and I'm gonna tell you, I don't blame my HR people. We gotta hire people because if we don't, we will not be in business. So it is very hard to get those few who have really come into this business with the right motivation, the right understanding. This is a changing time we're in now, which is why this call is so timely, Bob.
So let me walk it back a little bit then. Maybe not their heart is really in it and they're one of those people you described, but is there a way to help staff have a better understanding of the importance of their actions?
Absolutely, but that way is going to take a long time and it's going to take a lot of training and it's going to take cost to it, which is why I distinguished earlier between independent living, assisted living, and nursing homes. We do not have the money to invest in that. We cannot. We should.
Do you think it could be done if you did have the resources to invest in that?
Absolutely, 100%. I think I have ideas about that. I have ideas about like a training camp or boot camp, so to speak, for those people. I have ideas by people. I want them to go work somewhere else and then come back and work for us. And then I have lots of ideas, but they're ideas, and they're not realistic. They're not feasible, and I don't want to take your call up talking about things that I don't think are realistically possible.
At least not today.
Yeah.
Susan.
Software, I think, and you've kind of alluded to this, we have not quantified the return on investment. So I agree with you. I think there could be this boot camp. There could be, if resources were available.
Yeah.
Yes. But we've got to also acknowledge what is the culture we are inviting these workers into. And if we are inviting them into that institutional way of doing things, people come there and they're gonna burn out, and it's not where they want to be. I have seen millions invested in equipping more, do the CNA training and such, and they send them into nursing homes that are very institutionally run, and they're like, forget about it. I've got it. I don't want to be here. And so I think that's what is the cost of doing nothing in elevating our cultures. And you don't have to rebuild, but there is a cost. I acknowledge that 100%. But what will that return on investment be to retention, to elder outcomes, the satisfaction and such? There's definitely a return that you will experience. The cost of doing nothing is going to kill you. That's what's going to be the real problem.
Yeah. Something else that I would add is because there's various different ways of thinking about this. And one is, how do you when you are a person-centered care home, how do you train people as they come in for this? And how do you find the right fit for somebody and that sort of thing? But there's also a thought about how do you get people who've been working in your organization and it is, not yet person-centered. How do you equip them if you're asking them to change to a different way of doing things? And I think there's some real strategies there that can help equip people because in a traditional environment, it's very hierarchical and top down, where they, get orders from their charge nurse or things like that. And they have task lists. And I think even in person-centered care homes, you have some task lists of things you need to get done, but that drives everything and it shows that you're a good quality worker and it's rewarded. And so as you make those shifts, you kind of have to help people think about their jobs differently and that they aren't going to start their day on one end of the hall and go down the other and do one person assist at this time and two person assists next and all of that, which is very efficient and timely, but also has its challenges, right, as we've talked about, but help to articulate and help them work through how does your workflow look differently. And then also embedding that then in how people are evaluated and what's rewarded and all of those things. And that's why it goes hand in hand with practice training and systems so that they are all in sync with one another. And it's a evolving sort of thing, right? It can't always all happen at the same time. The other thing I'd say on return on investment too is I think that's just so important for going forward. And I will just share a couple of examples from Kansas. And, the demand for skilled nursing is maybe higher in some places than others, but between turnover costs and increases in census, there are several of our homes who've moved from the lower levels of the program to the upper levels of the program and reduce turnover from 110% to 30%, which is a huge cost savings, and have increased their census by an average of 10 more residents per day over time, which is a huge revenue booster. So when you add those two things together, that's huge. And that's not going to be the outcomes for everybody, but there's been at least a handful that that's true for. And so if you're looking for how do you get staff and retain staff, here's a potential solution. If you're looking for how do we become the provider of choice, two homes that I speak of have no hospital mechanism to send them people. It was all word of mouth, all word of mouth. So if you do good, you get good. You do well and you are what customers want, you become a preferred provider. You also have opportunities to attract a mix of payer types as well, which I think is important to talk about here. Not that you want to exclude any types of payer types, but you start generating a diversity of that potentially if you aren't doing that yet. So I think those are some of the returns on investment as well. You also potentially get higher quality staff. And when you have higher quality staff, you tend to not have the same types of disciplinary action as if you're always going to have some of those, but you have an opportunity to get better quality as well.
Yeah. So that reminds me of an article that I had sent all of you that I thought was pretty interesting. And they talked about stress of conscience, about how really good workers, the kind with the heart that Deke was saying are few and far between, they leave. And I know I've seen this in my own research. People who are really committed look at the care they're providing, either the institutional environment or their colleagues or whatever it is, and realize that they can't meet their own standards. And so they leave. And so we lose our best folks. Any comments?
I don't blame them.
Yeah.
Well, I think that speaks to what we're saying is that it really is incumbent upon all of us as leaders to really, really shape the culture and I'm going to use one of the words that Deke was using, accountability, but the support and the accountability. What does it look like to really equip the teams with the support and the resources that they need to be successful? And then it's that level of accountability. It's leadership really just saying this is what we need to do. And, we can debate, what needs to be done in the environment to kind of make it so. And there are some things it all will come with some cost. But what must we do to reshape the culture that we are inviting people into? Again, what are those systems, the support, the education that would be important if we're asking them to show up and do a new way of caring? What does it look like from the education side of things? What does it look like to fully equip them to be successful? And then it's the accountability among everybody, the KPIs, as you were referencing, Deke.
So I'll add to what you Susan, you and Lacey just said. What where does the care partners fit into this? Where do they truly fit into this? Are they the number two
Mhm.
person? That's important because we have preached this whole person-centered care. It's about the person, which is the elder, right? In my world, the resident. And we have made the staff member, the care partner, to your point, Lacey, with what you were just closing with. They're second class in this whole scenario, right? So again, I don't want to say what people don't want to hear me say, but the reality is we need to elevate their role
Yes,
in
yes, yes, yes.
to be even having this conversation. Because at the end of the day, they will keep getting suspended. They will be their role is so far below the role of the elder right now that care partnership, which we all try to do, is almost impossible to do because it's so far from it.
I'm just gonna speak into what you're saying because I think that's so important. And it's one of the reasons that like staff empowerment is so important. And for Peak, that staff empowerment is really all about our CNAs and direct care
Yeah.
staff, just because that's the group that has the biggest impact
Yes.
if you really empower them. And I did some research around COVID-19 to talk directly to direct care staff about their
Mhm.
experience during COVID and just asking them if they could change one thing about, and tell leadership locally, state, nationally, what they could do differently to support them during this. And by far, the largest theme was some respect and appreciation and not pizza parties.
Yeah.
Was
Yeah.
called out twice, not just the
Yeah.
notorious pizza party, thank you kind of thing, but like real types of tangible um, appreciation that they feel valued. And so I think there's a lack of that. And part of what Deke was saying reflects that. Just really elevating that role to some degree, showing
Yeah.
that it has
Yeah.
value and
Totally.
respect in and of itself.
Totally.
Yep. So I have about 20 more questions I'd love to ask you, but we're kind of running out of time and we promised that people could send in questions. And so I think Jay, who is somewhere here, Jay, have you been, I assume we have some questions.
Yes, we have many comments, and all of them complimentary and sort of reinforcing much of what's been said today. But there are two questions. One is very open-ended and could result in a lengthy answer. Another one is more brief. The brief question was, what does the acronym RIS stand for? And the other question, which is more open-ended, is how does implementing person-centered care reduce litigation risk?
Hmm.
I'll do IRS very quickly. I is individual discovery. R is routine and rhythm. And S is structure and spontaneity.
Hmm.
I can answer the litigation one to a
Oh,
degree.
no,
I
no,
will,
not
yeah,
too.
go for it.
You go first. You go first.
I'll say that person-centered care can potentially open you up to some different exposures that you may not have had. And I think really thinking through exposures that you can't, that are so high risk that you can't, and then what are the areas that um, are risks you're willing to take, and that be methodical, and the dignity of risk stuff is very helpful to that. But organizationally, really think like elopement is a huge risk. You cannot negotiate that, right? Or some other things. But the other piece is when you develop relationships with people and you have a deep knowing, and that there is that we are feeding into people's purpose and meaning and coming alongside them to support their goals, preferences, and priorities. That in and of itself helps as they're giving input in their care, you're having open dialogue and feedback with one another, um, that can help create relationships that lessen people's desire to litigate.
I assume you're including family in working with people
Yes,
because they're the ones that
absolutely.
generally initiate things.
Yes, absolutely. I just think of that as one and the same in
Okay.
my mind. So I'm sorry. Yes, thanks for calling that out.
Deke, you wanted to say
Yeah,
something.
yeah, totally. So, Lacey, well done, well said. And Jay and whoever asked the question, I would say that that is a great question, and is a question that literally makes practitioners like me be very careful in some of the I call it PDC, some of the PDC practices, person-directed practices we do. The reality is it doesn't matter what state you're in, because there are some states that are extremely litigious. Georgia is one of them, which is where I work. We are one of the quote unquote litigious hellholes in the nation.
Mm.
And if you are not careful about what you do, absolutely, person-centered care, person-directed care exposes you big time to that. Because, and I think someone said at the end, families come to you, they live with you, and a lot of people, because of end of life decisions, they see the nursing home as this could be their sign off in life, right? So they sue you because they know they could get some money, which you will get. If you sue a nursing home for anything, you're going to get some money.
Right.
It could be nothing, but it's cheaper for us to settle a lawsuit than to fight it. So you can get $10,000 from a nursing home for no reason. And person-directed care exposes you to that. So that's a reality. Great question.
So
Here's
how do
the-
you reduce that?
you
What?
can't. That's my point, Bob. We can't. There's not everything us on this call here
Mm-hmm.
can do or can reduce. All we can do is what Lacey said is practice, have good practices, make sure families like us. I will tell you a very sad story. I don't want to run of what's to run out of time that I have had with a person that came to us. This is years ago, and he was dead when he came to us, and he had wounds all over his body, and we took care of this man, and he lived for 5 years after that because of the good care he got, and his family loved us. And we called him every day and updated him on his progress. He was bedridden from the day he came to the day he died, and we were sued when he died. We were adjunct to a lawsuit they had with several hospitals, and that family got a couple $1,000.
Yeah.
But surely, as Lacey described, working with families, having a good relationship would minimize the number of people. I mean, that's true in all, I know, in all healthcare
It
laws.
is, but the
Yeah.
story I just told you, Barbara, was a
Yep.
family that we
Yep.
were very, very close with. So
Yep.
I'm just saying, I don't want to fool the audience here.
Mm-hmm.
I'm just saying, in some states, it is very easy to sue and get money.
Yeah.
Mm-hmm.
The
If
other
you,
thing I would say too, and this is not necessarily on this bigger level, but it is something to think about as you're navigating in person-centered care, what your exposures are, is I have a really important mentor that has taught me some things, and she says in person-centered care, if a person themselves is choosing something that could be harmful to them, and we're providing that education for them, and mitigating risks along the way, that's good person-centered care, right? But if we have a resident whose choice impacts another person or impacts our organization, that may not be a choice that we can support because it's no longer their choice that affects them. It's affecting other people now too. So we cannot just look at that person. We have to look at who is affected by the choice they're making. And it may not be something that we can support or mitigate to keep other people safe or to keep our organization safe. And so it's a constant balancing act between that and evaluating those different players in the situation.
Yeah,
It's
this is Jay.
complicated.
I just want to mention our last Advancing Excellence webinar really, I guess to this point, it was
Yes.
effective documentation to reduce litigation risk. You can listen to it, you can download materials. There's a summary and there's a PowerPoint available on our website. Just one last question. Uh, Asking Barb if she would publish a list of the articles that you had sent out to the speakers today. One of the
Okay.
people had asked for that. And do we have room for one last question? Is that
Yeah. Yeah, I think so. People
okay?
can leave if they
I
need to,
feel
but
like we get I feel like we get busy delivering care, admissions, med passes, call lights, showers, treatments that we fall into a task-driven schedule. While quality of life may look like sleeping later in the morning, coffee before care, watching a baseball game, and it is important to remember that life is not created just activities. What if we create an experience instead of all of these tasks?
I like that thought. I think about that as I think what they're saying is that living life and the different normal routines that staff are doing are sometimes a part of what people do in their own lives, in their own homes, tidying up their home, you know, getting breakfast ready, things like that. And I think that's wonderful. I would say that in terms of depth to answer that question in the peak information, which has lots of stuff associated with it, the meaningful life domain really speaks into that and kind of how to live that out or some suggestions for that and best practices.
And people have also asked for all the articles and references that you made
Yep.
during your presentation today, not just Barb's, but also every other article and reference material. Could you please share it with
Yeah.
people?
Sure. If you guys can send them to me, I will make sure they get posted, and I'm sure at some point we can send them out to people who are on the call today. Any parting thoughts from any of you? This has been wonderful. It's complicated, I think, is probably a nice summary here.
Yeah, that's my thought. This is not easy work.
Yeah.
I'm happy to be joined here by folks who are on that journey, Lacey, and by Susan, and they know this is not. So if you're going into this thinking it's going to be easy, I'm telling you now, that's
And I think, Deke, you've said something before that I think is a really important takeaway, and that is that we have lots of research and lots of frameworks and advice on how to do this, but when it gets down to actually implementing on the ground where Deke
yeah,
is, it's tough and it's never gonna totally happen.
yeah, totally, yeah. Don't judge yourself by what you think you're doing. The end line is never. You're never gonna get there. The end line, right? It's about the bridge in between and
Mm,
about you. Lacey said this earlier. It's about it's actually simple in that sense. It's about you giving the best
mhm,
quality of care that you would want for yourself as an individual. It's about giving that and just start that journey. Start it, jump into it, start it. It's going to end somewhere in the quagmire we've been talking about. But if you don't start it, it's never gonna
yeah.
get even close to being reality.
And I'd
Parting
say
thoughts? Yeah.
celebrate your successes along the way, that it is hard work, but it's work worth doing,
Yeah.
and celebrate your successes. And I would also say become a champion storyteller, because I think we don't do a good job of telling the good stories that flow from our communities. And I
Yep.
think that we should be champion storytellers and really make sure that we get the good words out, that we are doing the good stories and where a meaningful life is happening, and that should become part of our culture.
Yeah, the public image is much more negative than that, so that's good advice, Susan. Lacey, parting thoughts?
I would just encourage you, you know, that you've heard the hard, you've heard the good, but that when we're talking about residents and their lives, um, this makes a big difference, just like Susan said. And so this work is worth it. And um, I think any of us on this call, we all have our limitations on bandwidth, but we're part of your network. So there are lots of people out there that are who have lots of resources and ideas. And if you're stuck in, there's people to help you get unstuck. And there's people who've been in that, I think in this industry, it's sometimes really easy because of all of the things that kind of squish down on you to feel like you're a failure some days, even when you're doing really good and hard work. There's people out there that who've been just where you're at. So reach out when you're feeling in that spot so that you can get built back up because it's worth it.
Great. Wonderful. And thanks so much to all of you. Amazing years and years of wisdom, insight. So thank you very much. And thank you for joining us today. We have still almost everybody has stayed on. So thanks very much. All right. See you
Thank
at the
you.
next spotlight. Okay. Thanks.
Bye,
Bye.
everyone.
Bye-bye.
Bye.